Just checking it.
Please start.
Good evening to one and all. At the outset, I'd like to thank Parul sir and Shobha madam for the opportunity to welcome all of you. I'll welcome all of you to this important CME on family planning. I'll request Shobha madam to do the needful for welcoming all the guests and everything.
Thank you, Jigyasa. It would have been nice if we could have seen you, but then kindly share the prayer song. Let us begin with the prayer.
Dr. Shobha, you're on mute. You're on mute. We can't hear you.
Very wonderful opportunity for the governing council members as conveners with Dr. Ranjana ma'am, Dr. Ranjana Khanna ma'am, Dr. Bharti Maheshwari, and myself, Dr. Shobha Gudi, as co-conveners for this webinar on family planning. So I welcome all of you. Very warm welcome. And I'm very grateful to Dr. Jaideep Tank, Dr. Madhuri Patel, and especially to Dr. Parul Kotrawala, the chairperson of ICOG this year, for giving us this opportunity. So Dr. Tank was informed, but I think he is very busy, and he has conveyed that his best wishes are with us and to proceed. And of course, his year is going so fantastically well as expected, and there is much more to come. So it is my pleasure to introduce, let us not say introduce, because he is already well known to all of you, Dr. Parul Kotrawala, a very senior academician and consultant from Ahmedabad. I think it is redundant to read out a curriculum vitae at this point of time. Dr. Parul, we would like your message for the evening. Yes.
Thank you. Thank you, Shobha. Your enthusiasm and passion are tremendous for the issue of family planning and welfare. And this is perhaps the third session, am I right? During this year?
Yes,
you have focused this time on safety and the postpartum contraception. Both are very important because postpartum is the time when patients are receptive to the idea of family control and family planning. So today's webinar will be of immense use to many of our colleagues. Any updates are always welcome. So I wish you a very good webinar. Please continue.
Thank you, Dr. Parul.
Hi,
Parul.
Hello.
Hi, Dr. Shobha.
Hi, Ritu ma'am. Hi, welcome. Welcome. Wonderful to see. Wonderful to see you, ma'am.
Thank you.
Yeah. Can we have Dr. Sarita is there? Next, I would like to introduce. Yeah, Sarita. I'll come to you.
I think Dr. Sheila, you can introduce first.
I'll do, Sarita. I'll do. It's my pleasure. And of course, everyone knows that I'm very happy to introduce Dr. Sheila Mane, a very dear friend, a mentor for me, and a very well-known academician in
Thank you, Shobha.
So yes, let us have some blessings from you today, Sheila. Yes.
Good afternoon, everybody. And as Dr. Parul said, we know the passion of Dr. Shobha Gudi. She's been the chairperson of FOXI for family welfare, and all of us, we know that still she continues to work for this, particularly for this issue, and which is very important, I think, for us. And I must tell you that PPIUCD or the contraception is so important, particularly PPIUCD, what she has put up today. Because, so many private practitioners have still so many myths about it, not the patients, but even the private practitioners themselves. And it is very important to spread a correct message to them. So the counseling, which plays a very major role, I think definitely everybody will discuss about it. And I'm very happy to see that through ICOG, we see the enthusiasm of the governing council members, and Dr. Shobha is always ahead, and she has taken a this year also, which is started with Dr. Lakshmi, and Dr. Parul Kotadwala has also given her the permission, because we know the importance of this. So I wish all the best for today's webinar, Shobha, and thank you for that kind
Thank you
introduction.
so much.
And I
Thank you,
welcome
thank
all the faculty and all the chairperson, and I thank them for taking initiative to participate in these ICOG activities. Thank you.
Thank you very much. Thank you. Yeah. So, it's always an honor to introduce Dr. Madhuri Patel, the first ever woman Secretary General of FOXI, and she had really promised that she will be there, and she will be in the office anyway, and she will definitely log in, but I am not able to see her right now. As and when she joins, we will take it. So now I think Jigyasa and Anshul, if you can cordially invite our secretary, who can then introduce the guest of honor. Thank you.
Now, I'll request our secretary, Dr. Sarita Madam, to kindly introduce our guests. And
Yeah, but first you must say a few words about
No problem.
Dr.
I think she
Sarita.
said, Dr. Shobha, she said Secretary ICOG, that's more than enough. Thank you very much, Dr. Jigyasa. Don't worry. And at the outset, I must congratulate our three enthusiastic ladies led by Dr. Shobha Goody, Dr. Bharti Maheshwari, Dr. Ranjana Khanna for doing this fantastic program at every alternate month on family planning. It's wonderful to see so many people here, including Dr. R.P. Sunawala, who's also logged in. And Dr. Ritu is Dr. P.K. Shah, so many people. It's wonderful to see you. It gives me great pleasure to introduce our guest of honor today, Dr. P.K. Shah. Dr. P.K. Shah is a renowned teacher. He has he is the pioneer of ultrasound in India. And I remember in the early days how Sir has taught all of us how to do ultrasound. He has been the past president of many prestigious organizations, including the Mumbai Obstetric Gynec Society, the FOXI, and also many ultrasound organizations as well. He has also internationally received acclaim and been the FOXI representative to the Asia Oceania Federation of ONG, and he has been the chairman of the Imaging Science Committee of SAFOG. Sir, I've learned many things from you, and really I appreciate all the years that you taught us, and I was very happy to be personally a student of yours.
Thank you so much, Sarita, for your kind introduction. And it's a great pleasure to be in this FOXI ICOG webinar on family planning, aiming to reduce unmet needs. I think this is a time that we all gynecologists should wake up and take up the responsibility of really limiting the families in our country. Though the government has been doing little about it, we have not achieved the population explosion that we have. And we should realize that all the problems that we face in our country, majority of them are because of our population. So I think I must thank Shobha for persistently being after this particular topic for so many years. And I like the way she works, and I'm sure she will do very well. And we would like to have you in FOXI in a bigger place. Also, I would like to thank all the office bearers of FOXI
Thank you,
at ICOG, Dr. Jaideep Tang, Dr. Madhuri, Dr. Parul, Dr. Sheila Mane, Dr. Sarita, and I'm very happy to share this platform with Dr. Alka Kriplani, whom I met just few days back at Dehradun. And it's also nice to see all important people from Foxy, like Dr. Bharti Maheshwari, Dr. Ranjana Khanna, who are going to be the co-conveners and chairpersons also for the two sessions. The speakers, I think it's going to be a fun now, let me tell you. Though there is some storm going on in one place, Mumbai had some time back when I just landed from Delhi. So I think it's a nice weather also. And it's nice to see that you have picked up topics which are going to be covered by Dr. Sunita Singhal. And she's going to talk to us on post-pregnancy family planning, critical intervention. And our own Dr. Ashish Mukhopadhyay, PP IUCD implementation. And not only that, Shobha herself is going to cover the panel. And that is going to be on contraceptive, the oral contraceptive, combined OC pills. And again, a very surprising thing to see the panelists. I think all the names are all important people of Foxy. Dr. Parag Biniwale, Dr. Ritu Joshi, Dr. Manju Puri, Dr. Achala Batra, Dr. Reena Wani, all very good.
All aces,
people.
sir. All of them are aces.
Absolutely, absolutely. I'm really happy that you have picked up fantastic people from all over India, and I'm sure all those who have joined are going to have a lovely evening today. Thank you very much for making me a part of this webinar, Shobha, and I wish you all the very best for all your future endeavors. Thank you.
I'm not able to see, na, Sarita? Madam nahi aaye hain shayad.
Dr. I also haven't seen Madam. Maybe when she joins, she can give her address.
Yeah.
Yeah.
Yeah?
Yeah. Chairperson, yeah. Jigyasa or Anshul,
Yeah.
chairperson, introduce kariye beta.
We'll start the first session, for which I would like to introduce our chairperson, Dr. Ranjana Khanna Madam. Dr. Ranjana Khanna Madam was the National Vice President Foxy in 2017, is the founder president of ISOPA Prayagraj 2021 and 23, ICOG Governing Council member 2021 to 23. She was president AOGS from 2013 to 16. She was the organizing chairperson of various Foxy conferences and organizing secretary of National Foxy Conference at Allahabad. She has won various national awards and she is faculty in various national international conferences. Has delivered a prestigious Dr. Prabha Malhotra oration in UPCOG Lucknow, and she is author of many articles and chapters in various books and journals. Then our next chairperson is Dr. Professor Bharti Maheshwari Madam. Madam is a professor, head of Department of Obs-Gynac and IVF at Muzaffarnagar Medical College. And Madam is was chairperson Foxy MTP Committee 2018 to 20. And Madam has done a fellowship in medical education by MCI IME. She is also a governing council member of ICOG. Madam was Peacock and President Merit Obstetrics and Gynec Society. She has authored, edited many of the textbooks of Obs and Gynae, and published papers and review articles in index journals. Madam has also delivered the Kaminai Rao oration. Over to you, Madam, to carry out this.
A very warm welcome to everyone. A very good evening. First of all, I have immense pleasure in introducing the first speaker, Dr. Ashish Kumar Mukhopadhyay, a very good friend. He is principal and professor and unit chief, GNO, CSS College of Obs and Gynae and Child Health, Kolkata, Vice President Foxy 2016, Governing Council member ICOG 2021-22, past president, Bengal OBGYN Society, ex-chairperson, Medical Education Committee, scientific chair, AICOG 2022, WHO fellow maternal health. So welcome, Dr. Ashish Mukhopadhyay. We are waiting to hear you speak.
Good evening, everyone. Thank you, Dr. Anna Khanna, for introducing our first speaker. And thank you, Dr. Shobha Gude, and congratulations and thanks to all ICOG Foxy office bearer for successfully organizing this family planning webinar. That is we, Dr. Shobha and Ranna Madam, we are doing combinedly. And today we have very good sessions, and Dr. Shobha Gude has taken initiative already to make a very good program. And as we all know, Dr. P.K. Shah and other senior doctors has said already that Foxy ICOG, we are doing combined efforts to increase the family planning acceptance in our country, increasing awareness, increasing knowledge about the options, but still we are lagging very, very, very much. Still the acceptance and the implementations of all family planning program is very low. So today's webinar, it could be very helpful for all of us obstetricians, postgraduates to get more inclination, more information regarding the family planning acceptance. To now to Dr. Ashish Mukhopadhyay, sir. Yes.
Thank you, my
Thank you, Bharti. Thank you.
persons, the dignitaries of Foxy, ICOG, all my dear friends, and Shobha ji का क्या कहना है? Shobha ji and family
Sir,
planning.
कुछ मत कहिए.
नहीं, कुछ मत कहिए. No, let us come to
No,
the
बोलने दो.
topic.
Madam.
Sir, you are very gracious and you are very kind.
Yeah.
So we are always blessed to have a senior like you, sir.
I know.
Whenever we when we read or write a chapter on contraception and family planning, Shobha ji's face comes to my mind always.
Yes, sir. Thank you.
Just learning this.
Thank you. Let me say thank you.
So I'll try to share my screen now. Let's see. Can you see the screen now?
Yes. Yeah, we can.
Okay.
Actually, you are going to speak on a topic which is actually got a lot of misconceptions attached to it.
That's true. So with that introduction in mind, my topic is PPIU-CD implementation, challenges and solutions. The population of India, as you all know, is increasing every second. At this moment, it is 144 crores. And the increase, as Dr. P.K. Shah was saying, 0.92% from 2023. That year, it had an increase of 0.81%. And less than that, 0.6% was from 2021. So you can understand that every year, the multiples are increasing. I mean, the addendum are increasing. And that is why India alone are giving birth to 72,000 births. And that is why, we need to find out some policies where we can reduce this enormous rate for the population stabilization. Why this has happened? This is because there are certain things which we never have bothered about. Certain things we have inappropriately given stress on, and that is the reason why we have come into this position. One of such important parameters is this birth spacing. What is the spacing? Spacing simply means difference between two childbirths. So it can be birth to pregnancy interval, or it can be birth to birth interval, B2P and B2B. The concern about these intervals started in the year 2006 when WHO published a report of a technical consultation group on birth spacing. And this actually opened our eyes that what we have been doing, I'll show you what we have been doing. WHO recommended B2P spacing after live birth is 24 months. And spacing after miscarriage or induced abortion is 6 months. But look at the national scenario, what contraceptive methods we are using, predominantly it is covered by the female sterilization. That means the terminal method. And if you remember correctly, that whom do we do female sterilization? People who have already completed their families. They have already contributed to the population of India. And then we do the formalities of doing a sterilization, tying 2 tubes. And we used to think that by this we're achieving population stabilization. And that went on for year after year. And where do they get these services? 69% from the public health sector. As if the private health sector or NGOs, they have little responsibility, 25% responsibility in the reduction of the population burden of India. So, as we go up in the contraception pyramid, at the bottom you have the conventional method or not so scientific methods, but as we go up, the science and the technical improvement increases. And our IUD belongs to this category. And then we also realized that the postpartum period is the best method for family planning. Why? Because increase in the institutional delivery rate, now it is more than 90%, 98% in fact in our state. I don't know about others, but it must be very close to 90%. So women are available in the hospital, and immediately after the delivery, their motivation still remains high, and they can think about the family planning if we have already talked to her about that from the antenatal period. And not only the woman, but also the family members. Because for a woman's spacing method of contraception, or whatever it is, the woman herself is not the deciding factor. She has a managing committee in the family, consisting of the mother-in-law, the father-in-law, the sister-in-law. In short, the people who are remotely concerned with her future health and well-being. So now we have realized that there is a paradigm shift from permanent to spacing contraception, and that is the way we can achieve the population stabilization. How do we do that? Because if we keep 2 or 3 years in a woman's life free of childbirth, then those 2 or 3 years, the national population does not grow, and then the natural death rate strikes, and thereby the stability is maintained, and our goals are achieved. We took a long years to understand this basic, simple principle. But ultimately, we have realized, thank God, and now the focus is on the spacing method of contraception. So under the context, there was a resurgence in the PP-IUCD system, or IUCD rather, because which was lying so low in incidence, 1 to 2%, now has taken a major chunk of the family planning programs. Now, what are the significant achievements in this field? That the India-wide, there's a national strategy to increase the IUCD services. Everybody is doing this now. And there are global changes in thinking about IUCD. I will talk about the mechanism of action, which we used to think before, and now what is the fact that I will elucidate. New advances and new understanding about IUCD. WHO intervening in the middle, and they are creating WHO MEC, or medical eligibility criteria. So ultimately it was called rediscovering a languishing innovation. It is not a new thing. It has been there for a long time. Only thing that the misappropriation of the information, of the equipment, and misinformation about its technique or mechanism of action or acceptability, that actually pulled it down. And therefore it remained at 1 to 2% level. Now the time has come that people have started paying attention to this. This has coupled with a national high rate of institutional delivery by trained or expert people, and therefore we have got the opportunity to relook at the PP-IUCD. That's in the story in short. It has got a higher satisfaction rates, 99%, once they are convinced about this versus 91% for pill users and continuation rates than users of many other methods. And previously, the apprehension was that it will cause PID. No, it doesn't. The risk of PID in IUCD users is negligible. And also, another myth was, they will come back to the myths later on when we discuss about ectopic pregnancy, cancer, etc., etc. So this small little genius called T-copper 380A has revolutionized the concept of spacing method of contraception. It can also be used as a long-term contraception. Whatever way you use it, you can use it as short-term contraception. And about the mechanism of action, I think we have come away from the old concept that it creates the environment in the endometrium, which is not conducive for the implantation to take place by granuloma formation and chronic inflammatory reaction, making the cervical mucus thick, etc., etc., to a more proactive approach of the IUCD against the sperm, which is called the spermolytic action. It interferes with the ability of the sperm to pass through the uterine cavity. It decreases the sperm motility and function. It alters the uterine and tubal environment. So it acts to prevent pregnancy before fertilization occurs, and thereby you are not mishandling those countries where they don't want to kill an already fertilized ovum. So I think that's also important. So the mechanism of action has been elucidated. All these things have been elucidated by research. As I said, effectivity is very, very high, more than 99%. It is effective immediately upon insertion. Today, if you wear that, from tonight only, it will be effective. Immediate return to fertility when you stop this use, and is effective for 10 plus years. Normally, we recommend for 10 years, but it can keep its action for much more. About the use in category 4, that means the absolute contraindication and relative contraindication, we should be very clear before we go into the further discussion on this topic. The absolute contraindications are: the lady is pregnant, known or suspected. She has unexplained vaginal bleeding, mind the word unexplained. She has current PID, gonorrhea, or chlamydia. She has acute purulent discharge. She has distorted uterine cavity. She has malignant trophoblastic disease or genital tract cancer anywhere like cervical or endometrial. She has known pelvic tuberculosis, not the history in the family, etc., etc. She has at present known pelvic tuberculosis. And category 3 are those patients where not recommended for insertion as such, unless other methods are not available or acceptable. If a woman has AIDS but no antiretroviral therapy or access to care, a high individual risk of chlamydia and gonococcal infection, the risk, not the actual infection. Partner has current purulent discharge or STI. Then ovarian cancer, benign trophoblastic disease. So these are the different categories for you: category 4, category 3, category 2, and category 1. WHO, when it made the MEC, they did not mention about PP-IUCD as such, but they have made the MEC for IUCD. And we have extrapolated few of them from that MEC for IUCD. If a woman has a normal full-term vertex pregnancy, we can assume that she probably doesn't have a distorted uterine cavity, malignant trophoblastic disease, etc., etc., tuberculosis. And so you can use judgment also to understand category 4. So category 4 doesn't need a sophisticated investigation always. These are the most likely precautions that we usually advocate. In the most typical situation, providers should watch out for unresolved hemorrhage, still having worrisome bleeding, some hemorrhage which is being controlled, or something which is under treatment or investigation and a diagnosis have been made, is not a contraindication for PP-IUCD. Chorioamnionitis, puerperal sepsis, obviously presence of an active infection in the body, we will not allow. Then rupture of the membranes for more than 18 hours, history of, potential or infection, and recent purulent cervicitis. So these are the precautions that you take to exclude all these things. So we have advantages and limitations. I think there is no point discussing in detail of all this because all of you, this is a very elite crowd and everyone knows this. It is effective, reversible, long-term method, safe, convenient, and no increased risk perforation or infection. Doesn't affect the quantity or quality of breast milk and greater coverage of population. But we have certain limitations, which is the principal topic of discussion today, and their solutions. We will discuss one by one. So I'm skipping this slide now for the time being. What happens to the cases of anemia, IUCD and anemia? Because a lot of our Indian women, in fact, more than 50% in the last NSHM data that shows that they're anemic. Monthly menstrual bleeding increases slightly with the IUCD, especially in the first 3 months. It's a natural phenomenon and thereafter it settles down. Blood loss, and you need to counsel about that. Blood loss which results in anemia is also rare. Therefore, it is safe to provide an anemic woman with an IUCD, and that is category 2. If a woman is anemic and has the IUCD in place, continue to treat anemia with Arner folate. Means that anemia, presence of anemia is not as such a contraindication to use of PP-IUCD in the fear or apprehension that it will bleed a lot and the patient will become more anemic, etc., etc. That's not tenable. Safety data has been obtained from the Cochrane's review, and the author's conclusion was that the immediate postpartum IUCD, they appeared safe and effective, but expulsion rates appeared to be higher. And then with the interval insertion, that was the concern. It's an old observation, and thereafter a lot of studies came into place, and a lot of observations also came into place. We'll come back to that within 2 minutes. So what are the timing of insertion? This is crucial. IUCDs can be inserted postpartum, that is right after birth, that means immediately after the delivery of the placenta, within 10 minutes of delivery of the placenta, which is also known as a post-placental insertion. The second is soon after birth. How soon is soon? It's immediate postpartum, that means less than 48 hours after delivery. That means essentially it is from 10 minutes after placental delivery up to 48 hours after delivery. It can be during cesarean section, which is known as the intracaesarean, and also it can be 4 or more weeks of postpartum. So here is the graph over here. You can see that the ideal method of insertion of IUCD is post-placental. That means immediately after delivery of the placenta or within 10 minutes of the delivery of the placenta. Within 48 hours, it is still safe, but you cannot introduce PP-IUCD between 48 hours to 4 weeks. There is increased risk of perforation, there is risk of expulsion. Although in practical reality, we haven't seen perforation, not a single case. And expulsion, it also, we have kept it down. I'll come to that later on. So this is post-placental insertion. This is how you hold the IUCD, and for which I prefer a long Kelly's forceps, also known as the placental forceps. And in cesarean section, it may be difficult to use the Kelly's forceps, therefore we use the fingers. And our clinic actually contains this visual series, how to introduce this, just to show this to the patient, because otherwise she will be very much apprehensive and panicked. Steps of insertion, all of us know: counseling, ensure that the instruments are ready, confirm that the woman wants the method, identify the cervix and clean with antiseptic, and slowly insert the IUCD and ensure fundal placement. This is the way the counseling goes. The instruments are very simple. It should be kept ready. The aseptic technique should be followed. And this we have in our clinic, and the patient always appreciates this kind of visual, which is running in the OPD complex. Look at the way the Kelly's forceps handles the IUCD. It places close to the fundus and then gradually takes it out, just moving a bit laterally. So today now we are going to discuss some of the challenges. And all our observations are based on our 3-year study between 2015 to 2018 and subsequent publication, and also study by our PG student. I will discuss one by one. This is a 3-year study result. We had experience of 34,000 plus population who are all total antenatal care. All total vaginal delivery was 15,000, more than 15,000. Cesarean delivery was 13,919, roughly 40%. And then all total number of the deliveries were 29,200. Total post-placental insertion was 735. That means roughly 19.5 or 20%. I think it can be improved. And then we also observed that the total follow-up was also quite, unsatisfactory because of the many pressures in the family. They cannot come for the. So we resorted to the telephonic follow-up also, but that also was quite not a very good result. Total expulsion was 29 in 3 years, and etc. etc. This we published later on as our observation, and also one of our MD PGs, she did the thesis. I'll come to that later. The first point of concern is the expulsion, partial or complete. The term is self-explanatory, what is partial and what is complete. It can occur silently while you are introducing it, because you are not seeing it properly. That's why you have devised many models for introduction, Mama Natalie and all those. So they can occur silently. New onset of irregular bleeding may happen if the lady has to have some symptoms. Expelled IUCD can be seen or seen in the vaginal canal, which is partial expulsion. The patient may miss the menstrual bleeding also, or it can have missing and longer strings. So all these are complications of the expulsion. So you have to conduct an appropriate, I'm going side by side, the problems or the challenges and the solutions. You have to conduct an appropriate assessment, including the pelvic examination, very important, to rule out other possible causes of symptoms, such as infection and pregnancy. When other possible causes of symptoms are ruled out, image based on findings are there. If complete expulsion of the IUCD is confirmed, for instance, seen by the woman or confirmed by the ultrasound, insert IUCD if desired after assessing the client for excluding pregnancy and infection, or counsel for another family planning method. If partial IUCD expulsion is confirmed, you cannot no longer use that. Remove the IUCD and push another IUCD if desired, and appropriate or counsel for another family planning method. If the IUCD appears to be embedded in the cervical canal and cannot be easily removed by the standard technique, then a specialist care is of course needed. Otherwise, the much of the care so far is not very special. Expulsion rate has a wide range, and they have reasons for that. The range is 3 to 37%. It's quite high. But in general, expulsion rates for PPIUCD range between 10 to 14%. That's also high. So, a lot of studies came after this, which actually proved that a good technique can reduce expulsion to 4 to 5%. So, if you can keep the expulsion rate below 5%, you should be happy. And obviously, post-placental expulsion rates are lower than postpartum expulsion rates. So, therefore, it will always insist on the post-placental expulsion. Another thing is that if you cannot do post-placental expulsion, and you think that, okay, we have time for 48 hours, we'll do it tomorrow, that tomorrow will never come. Because the lady once goes back to the postpartum ward, she will never come back to the, side room for insertion of the PPIUCD. She has lost it, and you have lost your patient. After so long and so repeated counseling on this pregnant woman from the antenatal period, have lost the opportunity of PPIUCD insertion in one patient. So remember, your post-placental is the best chance for all practical purposes. So you can reduce the expulsion by using correct technique, the correct instrument, that's the Kelly's forceps, and insert at the correct time. As I said, post-placental is the best. If you can, by chance, you can keep it to a minimum. The early insertion, that means within 48 hours, you should keep it to a minimum. Now, second challenges is the string problems, which we took some time to discover, because these patients did not come to us initially. And later on, we realized that these PPICD patients, because they realized that they are coming to the government hospital, the PPICD will not be removed so easily by the doctor. So they went to some private practitioners and they got them removed. After some time, when we came to realize in the 3 years' time, one year we lost like this, then we found that there is some string issues. So what are the string issues? And we need to find out, and also find out a protocol for missing strings. We use this protocol when we do not find the strings of the IUD protruding from the cervix on post-speculum examination. But when to look for that string? We never touch that string or feel the deficiency of the string till 3 months. And this protocol is self-explanatory. If you find the string, reassure the patient, provide additional information. If it is not found, ask the patient if it has fallen out. Sometimes the patient may be able to say. If it has really fallen out, then offer to replace the IUD. If she is really motivated and you have been able to convince her about the benefits and uses of the PPI-UCD, then she will opt for the replacement of the IUD. Then you insert the IUD, or at least insist on other method. Don't insist on the IUD itself, but you can explain the other methods to the woman. Then follow up at 12 weeks and record the result. Now, if the patient cannot remember, not sure, then you send her for the imaging, ultrasound, to locate IUD. And then we follow up at 12 weeks and record. And in the cases where it is curled inside the uterus, then offer to replace the IUD. So if strings not seen at 3 months, repeat the protocol from start. If strings still not found, either reassure and follow up, or remove the IUCD with probe and replace. There are certain things about the string. Do not cut the strings routinely while placing the IUCD postpartum, postplacental, or intracesarean. In cesarean section, do not pass the strings through the cervix. Leave it in the lower uterine segment. Strings will typically descend during involution and curl in the posterior vaginal fornix. Clients are urged not to bother about the strings for first 3 months. You have to reassure them. Of course, she will believe you only when she trusts you. Otherwise, she won't. She will go to another doctor. Sometimes they may remain in the uterus, but this is not usually a problem. Let it be. So you have to convince the woman that this is not a problem. Strings can be cut, but only at certain special cases, follow-up visit. If pelvic exam is not possible, then it is not necessary to cut the strings. Strings should be cut if the woman complains or they protrude from the introitus, which rarely happens. So the myths and misconceptions that we are talking about has now come. A lot of misconceptions about the IUCDs in the general people mind, but I was surprised to find some of them in the doctors and service providers mind also. We have to emphasize that IUCDs do not cause PID, nor does it intensify the existing or pre-existing or previous PID. They do not cause cancer anywhere in the body, do not increase the risk of contracting sexually transmitted infections, do not make a woman infertile, do not increase the risk of miscarriage when a woman becomes pregnant after the IUCD is removed. They do not cause birth defects. They do not move to the heart or brain. It's a very important message. You can use a microphone, loudspeaker to say this in neuropedy. Do not cause pain or discomfort for the woman during sex. Substantially reduce the risk of ectopic pregnancy, because the previous concept was that it encourages ectopic pregnancy, and therefore don't use IUCD in patients with history of PID or something like that. That is absolutely not. So there are many advantages for the client, but we have equally advantages for the doctors and service providers. The limitations are changes in the monthly bleeding pattern, of course, will be there. Slightly higher rate of expulsion, 8 to 14%. Let us see our studies. What does it say? With good technique, it should be 4 to 5%, meaning 86 to 92% retention, and requires special training for the providers. Of course, that we always maintain that no person apart from the trained people should put in the PPI-UCD. The third important point is the changes in the menstrual bleeding. In monthly bleeding patterns happen especially in the first 3 to 6 months, typically irregular and unpredictable. Women cope with this better if they are counseled about it prior to insertion. Like when we do the counseling about DMP, adiponectin hydroxyprogesterone acetate, like that, you should always convince her that yes, this will be acceptable to you. Is perceived lesser by the postpartum women, prescribe iron, folate, and follow-up, and provide reassurance and attention, not much of worries. You can try some medicines like tranexamic acid, 1500 milligram 3 times daily for 3 days, then 1000 milligram daily for 2 days, quite high dose. NSAIDs 2 times daily for 5 days. Provide iron folic acid tablets, of course. There can be menstrual cramping and pain also, maybe less for the postpartum women, but it can happen. Provide assurance that it is common in the first 3 to 6 months, and then you can offer certain medicines which are pretty elementary. So, in prevention of the complications, there is, and we suggest careful screening of the clients, strict adherence to infection prevention technique. That's very, very important. Follow appropriate insertion technique. Perform procedures slowly and gently, and continued communication with the woman. We haven't seen uterine perforation in our studies, nor have we heard about this. Maybe some anecdotal reports are there, but they are so rare that they don't need mentioning, because you need to always be on the encouraging mode, not in the discouraging mode. Severe pain in the abdomen is rare, but always remember the two possibilities. One is the endometritis, salpingitis, PID. There are only two important causes of severe pain, and the other is the ectopic pregnancy. So be very careful about these two conditions. So at the end, we can say that we achieved a lot of success. And what are the roads to this success? What are the contributors to this success? Number one is a 98% institution deliveries, as we talked about, 81% of which are at public institutes, provides an opportunity for expanding postpartum family planning services. Second is a rapid scale-up of PPI-UCD from less than 1% in 2014 to nearly 40% at present. The state now leads in the PPI-UCD acceptance rate in the country. Our state has achieved that. So I think we are quite successful in that. Of course, there's a long, long way to go. Strong counseling and good quality of services ensure acceptance among the people. West Bengal has one of the lowest discontinuation rate for IUCD, but I suppose now many states are coming up to compare this, and I think all the states are doing well at the moment. In our system, we have involved the medical colleges, all the medical colleges, because they're in a commanding position in introduction of PPI-UCD, post-abortion service, or PAIUCD together, and build a strong foundation for training. We have also done integration. Without integration, our ladies won't come to the hospital, because if we cannot give the vaccination to the child, she won't come, because she has to come to the hospital for twin purpose. So integration is extremely important. And the linkage between the medical college and other facilities strengthened through the training partnership and handholding. We often go out for the training purpose. There's something called skewed method mix. That means not only one method of sterilization or one method of PPI-UCD, one method of oral pills, but you have to, you can emphasize on any particular method, but you have to explain everything to the clients. Previously, emphasis was largely on the sterilization method, so now it has shifted out of that. That's the paradigm shift now, and no wonder the share of the spacing methods are now increased by 30% from NFHS 1 to NFHS 4. You can see the graph here. That's quite an improvement. I think we can improve further. This was our study in our medical college, where one of the PGs, he took up this subject and did the study, and we have actually reported this. And you can see the sample size was 573 mothers. The result in short are expulsion 12, that means 2.09. I think quite acceptable. Continuation was 546, 5.28%. Quite an encouraging result. This low expulsion rate was chiefly because we never allowed any untrained person to do the other. This is the problem that we put on the platform, that I think we have faced this problem, always started late, and we took time to realize this. The strings not visible is a major complaint by the patients or the clients and their relatives. And this stems out from our original advice, which I think was a wrong advice, to palpate or feel the thread for the IUCD during menstruation to see if it is there or not. That was a routine post-operative, post-insertion advice in our times. And I think that legacy has continued, and the ladies have become very, very, itchy about the presence of strings there. So how to manage the strings, I think I have suggested. You can try it at your own hospital. I'm sure you are doing your one of the own methods. And the reasons for what were the acceptance and failure, you also listed out. The major cause for acceptance was no remembrance once inserted. That's a major headache is gone. My doctor's advice must be a good one. That means the doctor's relationship is very good. And the reasons for the failure or other reasons to decline was lack of awareness, of course, at the top position. But above that, we have partner and family refusal. As I said, ladies in our country, they are not in a position to take decisions for their own benefit or health. It is the managing committee at home which decides. So she is nobody to take some decision because she is financially dependent on others. So in conclusion, it is a demonstrably safe, effective, and high retention rate. Everything is good about it. Expulsion rate, as you can see, we could bring it down to 2% level. That means it is controllable, it's manageable. It can be kept less than 5%. And that way the acceptance will be much higher. Proper technique. In our study, PPIUCD was well accepted by the study population because of high efficacy, no remembrance, etc., etc. I have mentioned. It's also to arrange training on PPIUCD in order to increase the knowledge and skills among the healthcare providers. So it should be integrated with the maternal and child care services, MCH services, in order to promote the use of contraceptive device. With the high level of acceptance, despite low levels of awareness, there can be need to develop strategies to increase the public awareness on this issue. I thank you, gentlemen, for your patient hearing.
Thank you.
Thank you.
Thank you, Dr. Ashish. Yeah.
Should I stop sharing now?
Yes.
Yeah.
Yes.
Thank you, Dr. Ashish. That was a brilliant
No
talk.
Very
Absolutely
good.
complete in itself. And but what I want to emphasize is that there is a big role of counseling, because if you don't counsel your patients well, they always feel cheated. And you should tell them about all the drawbacks that could be there. There could be heavy bleeding, but that could also be because of postpartum blood loss. So you just counsel them, take them in confidence. That is very important, because in my private practice, I had 2-3 such patients who came for secondary infertility. They had no idea that PPIUCD had been inserted. So they came to me that, madam, 7 years back, I had a child and it was a normal delivery in the medical college. And after that, I'm not conceiving. And on examination, I found that the PPIUCD was there. So I said, Ki, there is an IUCD, so you must be knowing about it. She said, no, nobody told me anything about it. So, that way the patient feels cheated. But you should explain, counsel, and then insert, I feel. And another thing is just tell the drawbacks. So always the patient's trust comes with you. So that is even important during the interval IUCD insertions that we are doing. So, and PPIUCD is definitely a very, very good method of contraception.
And Dr. Anjana, we are doing for the PPIUCD, we all are doing counseling from the antenatal time, from the pregnancy time, and we take the we try to know the inclination about the family planning method just after delivery, and even we take the consent, and we again re-sign it consent just before delivery, because once the patient come in the labor, she is not in the sometime stage for the counseling and telling that. So once if she is a book patient and we can counsel her, so we have to tell her. But as you have said that we take the written consent and inform that we are putting the
That they
IUCD,
say
only
that
then we
they
do that.
made us sign a paper, but we thought कि delivery के लिए paper sign हो रहा है.
No, 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 no. Yes, 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 yes.
And I'm just
Fine.
saying there are isolated instances where this can happen if there's a lot of
Yes.
rush. So
And
this can happen that you don't inform the patient and just put the IUCD
yes,
in.
that is thing, and it's still very major issue that all have a very big myth at the very big level that it can be migrated. So a woman stay scared that they will not put the IUCDs. So we are trying to remove this myth and saying that if it would be done at the proper place by proper trained person, so chances are not there. So Ashish sir, excellent lecture, very good, informative, all
Very good.
comprehensive, and I think we should move to next session, next topic, next speaker.
भारती
Yeah.
एक
Yeah.
बात कह सकती हूँ,
Yes,
especially
yes.
thankful to Ashish da because the conference is starting just tomorrow for them.
Yeah.
And you know, today he agreed to take this on, you know, and I also did not leave him. I said it's okay, but this is very important. You must
But
come.
Dr. Ashish
and-
wanted to say something just now.
I just wanted to say that there are a lot of dusht chakras involved in this, consent taking and counseling. I'll tell you what.
I liked that managing committee at home. I
Yeah.
really liked it.
And I was inspired by Dr. P.K. Shah, who always used to take any decision in the managing
And
committee.
the chairperson is the mother-in-law.
Right. Chairperson is mother-in-law, and the biggest contributor is the sister-in-law. She is
Oh.
concerned with health and well-being of the lady. So coming back to the point, I'll say one thing that the counseling in our institution, I can say for certainty, it doesn't happen on a small episode, on a single episode. It happens repeatedly, every visit they are counseled. And in the end, they are given a written signing that yes, and even after that, during the time of delivery, they will say that I didn't know that it was for ICD. I thought it was for something else. They clearly know everything. And this is actually instructed by the managing committee. I'm sorry, Dr. P.K. Shah, I'm putting some blame on the managing committee, but they deserve it. They are tremendously powerful, extremely talented, and very, very manipulative. Who are dealing with a female population, they know very well that the father-in-law with a curved mustache like this will not be allowed into the OPD, gynae OPD. So what happens? They push.
I don't agree. I don't agree.
This is the counseling, counseling हम लोग बहुत किए हैं. लोग ऐसे दुष्ट ऐसे बोला दुष्ट चक्र.
दुष्ट चक्र तो है, पक्का है.
ये
और
Acha, I
ये भी
didn't know
सच
you
है.
rate the sister-in-law
ये भी
higher than
सच
the
है.
mother-in-law.
ये भी सच है कि in the private sector there is a huge provider bias.
Yeah.
And most consultants feel that this is a very unscientific method, and that is the reason they don't use it. They don't offer it. They feel that it is something very old-fashioned, and something like. So I just wanted to say that postpartum as well as intra-cesarean.
Yeah,
Please insert IUCD because it's reversible. It can be taken out at any time. And at least
exactly.
50% will retain it. Yeah, they will agree to continue.
So all due apology to all the private sector providers, there are some of them are very, very famous for opening or taking out the IUCD. And they take money for that. हम लोग एक भी पैसा नहीं लेते हैं insert करने के लिए, but for people they charge money, and they will do that without any hitch in their mind. और में जाए अपना नेशनल फैमिली प्लानिंग
सर
प्रोग्राम.
ऐसा कहा जाता है कि गवर्नमेंट वर्क इज गॉड्स वर्क. तो आप तो भगवान का काम कर रहे हैं, वो तो खुद में ही अपना प्रसाद है, उसके बाद आपको क्या मिलेगा? But the thing is, on a very serious note, I think it is our request to all ICOGians, all Foxians, please do not remove the IUCD. If the woman is keen on getting it removed, she should go back to the primary provider. But
Yeah.
even if you are forced to remove, then please immediately provide her with an alternative contraceptive
planning
method.
method, right.
Not if she wants another child.
No, that is okay. But then you can explain to her, you can do everything. But just officially removing something from a PPIUCD patient, I
Yeah.
think that's a kind of,
Bharti,
doing some crime. Bharti.
Bharti, we are at risk of
Yes, yes.
closing on this session only.
Yeah. No.
Yes,
I'm
So
sorry.
interesting.
Please go
Please
ahead.
continue. The other speaker is waiting. Ashish sir, thank
Yes.
you very much. Thank you.
Thank you, Dr. Ashish. Thank you. So now we have another speaker, and she is Dr. Sunita Singhal, and we all know that she is a basically a country lead in the clinical sciences and training family planning, and she is she is having the country and global leadership, and in the JPIGO. And madam is over 30 years of experiences in the family planning, maternal health, adolescent health. She is a technical expert in sexual and reproductive health program, providing technical and strategic leadership for the sustainable and scalable interventions and health system strengthening, as well as national resource person and core group expert for the RMNCH program of Government of India and advisor, core group member, National Task Force on the Family Planning. So basically, we know that she is the right person to give next talk. And that is a very important issue, postpartum family planning programs, how to increase implementations. And now to Dr. We are very keen to listen to your madam topic. So now to next speaker, Dr. Singhal madam.
Thank you very much, madam, for that introduction. Am I audible and is my screen visible?
Yes, madam, perfectly.
Thank you very, very much. Once again, I was really listening to the very interesting conversation, and
Madam,
I wish
you have to do full screen. You have to do full screen.
I will do. Don't worry,
Yeah.
don't worry.
Yeah,
I'm
yeah.
going to do that. Right, ma'am. So thank you very much. I've just listened to a very interesting conversation. In fact, I can that sends me back to my Safdarjung Hospital days when PPIUCD was launched way back in 2010. This is how it has evolved. So going forward, I just will start my conversation with 2 comments, and please bear with me. So first of all, is that let us give the woman the choice. We have really come forward a lot, you know. We do come from that generation where we've seen the kind of women that we have been talking about recently. But things have evolved. Let us do our justice by helping the woman, empowering her to take a decision. Let us respect her choice, respect her decision, and let her make a voluntary choice. And the management committee, I really love the word management committee. So let's handle the management committee to the extent possible. Let's do couple counseling. Let's allow her to call her family. And we may not be able to help all of them, but yes, some of them definitely we will be able to help. So that should not stop us from doing that. So with that, I will come to Dr. Ashish has really made my job very, very easy because he set the context by talking about PP, IUCD. So PP is postpartum. So when it was started in 2010, IUCD was the only postpartum method which was understood in the country. But today, over the last over 10 years, we've really evolved. So today it has a very, very important intervention. And if you see the screen, it is post-pregnancy family planning is the term that is used. And Shobha specifically asked me, you talk about post-pregnancy. So what is postpartum and post-pregnancy? So I will start my talk with a few clarifications regarding some of the terms who are standard, some of the terms which are not standard, and people use it at their own discretion and decision, sometimes in the program, sometimes in the maternal health side, sometimes clinically. So I will define the postpartum period and the key terminologies, discuss the rationale of post-pregnancy. I repeat, post-pregnancy is the word I'm using here. And then, of course, what are the postpartum contraceptive choices, and discuss the post-abortion contraceptive choices. So from postpartum IUCD, we have come to an era where we have a lot more options to give to the woman So she has a choice. She has that basket of choice in front of her to pick up from. Now, before that, I would also like to touch upon the priorities, the global priority as well as the priorities of Government of India, India's vision for FP 2030 program. And if you look at my last point, which is the quality. So one of the commitments of Government of India is enhancing the quality of services and strengthening data systems for PPFP and PAFP. So this is a priority, not just globally, but also for India. Now, what is post-pregnancies? It's nothing but just, or as all of us know, that after a woman becomes pregnant, the outcome could be either she has a full-term delivery or a preterm delivery, or she has a miscarriage or abortion. So any woman who has become pregnant once, irrespective of the outcome, if she adopts a family planning method, or if we offer her a family planning method, then this is called the post-pregnancy period for family planning services. So this could be postpartum. If she delivers a baby, then it becomes postpartum family planning. But if it's a miscarriage or an abortion, it's called a post-abortion family planning method. Now, why is this a critical intervention, as Shobha Gudi asked me to define this further? So it is because this is the time where in India, the women come in contact with the healthcare provider, whether it is in public sector or it is in the private sector. Woman has a contact with the provider, not just the woman, even the family members. They have this contact, and this is an opportune time. And as Dr. Maheshwari and Dr. P.K. Shah, they were all talking about counseling. Of course, counseling is critical. So you have so many opportunities here. So here is one point that we can do good counseling of the woman, and if the family members are to be involved, we can involve them also. So what is PPFP, postpartum family planning? Now, postpartum period for us, the clinicians, is up to 6 weeks after delivery. But when it comes to adopting a method programmatically, we define this initiation of and use of FP methods for the purpose of preventing unintended and closely spaced pregnancies through the first 12 months after that. So that's called the extended postpartum period. So quite a lot of you must be aware with this term, extended postpartum period. But now, globally, there are a couple of other terminologies which are in use. So one of the terms is that the opportunity of interacting with the woman and the family while she comes for the delivery, that is before discharge within 48 hours. So you offer voluntary contraceptive counseling and services. So even if she doesn't adopt a method, if you've done counseling, you hit her with a hammer once, you put in a dent that yes, there is something. Even if she doesn't take method at that time, a point of time, there are other opportune times when she can come and take it. So I will touch upon that a little later. So early postpartum period, as we can call it, from 48 hours to up to 6 weeks. Extended postpartum period, 6 weeks to 1 year is the extended postpartum period. Now, Dr. Ashish has really spoken about the PP-IUCD. These are the timings, so I will not touch upon this. Let me go further. There's another term called IPPFP. I stands for immediate. Now, what is immediate PPFP? WHO has come up with this terminology under their high impact practices that they come up, based, which is these kind of briefs which are based on multi-country experiences. So if you want to read, you can really go to this resource. And this means that this is nothing. It is the same thing, but they call it immediately, that you immediate because when she's in the hospital, the time starts now. Whether she takes the method or not, but you start with the counseling. So even good counseling services is good enough to, sensitize the woman. So this is offering voluntary contraceptive counseling and services as a part of the facility-based care after childbirth prior to discharge from the health facility. And this includes a time frame. So the important term is pre-discharge from hospital up to 1 year after childbirth. So this has really good impact. Good number of women take up, and it really helps improve all our statistics now. So I said post-pregnancy includes post-abortion family planning methods also. Now this is a little gray area, because we all know where the abortions are happening, how many abortions are actually happening in the public health facilities, how many abortions are reported, what is the data about abortions which is available in the country. And now with the MMA on the scene, of course, even that requires a prescription. We all know that, but we know what happens on the ground. So that data is difficult to get, but then that's another area that the government wants to focus on. So PAFP, we may define it as offering voluntary, I repeat, voluntary contraceptive counseling and services at the same time and location where women receive facility-based post-abortion care. Or, right, so either when she comes to seek services, post-abortion care services, or before fertility returns after the abortion. So this is to prevent an unintended pregnancy. And we all know the return of fertility after a first trimester abortion is 10 days, and after a second trimester abortion, it is 4 weeks. And after a medical methods abortion procedure, again, it is around 20 days. Now, as I said earlier, the government policies have also evolved over time. There has been a paradigm shift, I must say, that from the population control as one of the targets, or the targeted approaches in the 80s perhaps, the government has moved on to the maternal and child health services, improving the quality, improving the morbidity, mortality for the mother and the child. So today we talk about the family planning methods adoption, taking care of mother's health as well as the child's health. And let me tell you, we have really come far enough. If many of you may know it already, that in India, the TFR, the total fertility rate, is 25, more than 25 states have already achieved that rate of 2.1 TFR. TFR means average number of children that a woman will have during her reproductive life cycle. So there are many states who are less than 2.1, and the time is not far, perhaps, that some of our states will line up with the affluent countries like Denmark, Switzerland, etc., who are, really, they have a reverse kind of policies that if people produce children, they're given incentives. So we have to be mindful of, futuristic vision of all those things, that whatever population we have, but then we need to have a differential approach. Maybe some pockets in some of the states really need more focus, but at other places, it is not the numbers that we are looking for. But yes, very right, we are looking for the problems that the country is facing. And the problems are some pockets. There are too many children, too frequent, and too early. So teenage pregnancies in India, still 6.9% pregnancies are of children who are under 18. And as Dr. Ashish said already, he has spoken about it, that younger pregnancies and the spacing, he's talked a lot about it. So we all know what are the implications, that if too quick pregnancies happen, and that is one of the reasons why this postpartum or post-pregnancy family planning concept has been brought in and is being promoted not just globally, but across the country as well. And there is enough data to see that if you go by the DHS surveys from various countries, 95% of the women within first year want to avoid a pregnancy in the next 2 years. But out of these 95%, 70%, 7 out of 10 are not using any contraception. And then frequent pregnancies, how it impacts the health of the mother and the child who's already come and the child who's about to come. It can avoid 30% of maternal deaths and 10% of child mortalities if the pregnancies are spaced more than 2 years apart. Closely spaced pregnancies have a highest risk for both the mother as well as a baby. Of course, the anemia, PPH, preeclampsia, etc. is there for the mother and for the baby, preterm, low birth weight, and small for gestational. We are all aware of all these things. So this is one of the reasons why a PPFP should come into place. Now, the another rationale is the myths. Dr. Ashish also talked about some myths, and Dr. Maheshwari also spoke. So the myth is women think that they will breastfeed, or after delivery, they cannot become pregnant so soon. So they are reluctant. They don't even think about it. They're still rejoicing that perhaps the delivery and don't think of contraceptive methods. So, but the studies across countries have shown that more than 50% become sexually active within 4 to 5 months. And breastfeeding is not lamb. We all know that. They think if they are breastfeeding, they will not conceive. And that proper lamb or intensive breastfeeding goes down. If you see from 60% after, within 2 months or so, it comes down to just about 1% within a year. And the menstruation. So some of them don't menstruate. So return of menstruation does not mark return of ovulation. That's something very, very important, which needs to be told to the client, to the women. She can ovulate before she menstruates. And we all have seen very, very often that women come to the clinic. Something is happening in my tummy, doctor. Pehle dekh lo, please, jara kuch hil raha, and you put your hand and you find it's the fetal movement. She's already into 5 months of pregnancy. So, because she doesn't realize she had amenorrhea, post-delivery amenorrhea, and there she conceived, and now she's 5 months pregnant. So that that concept, is really very important for the clinicians out there and the healthcare workers, the nurses, the ANMs, and the other medical officers working in the remote areas, and even some general practitioners. So they must know these basic facts. And so again, spacing, I think Dr. Ashish spoke a lot about it, so I will skip this slide. But I will also talk a little bit about post-abortion family planning, a little more, in the sense that the post-abortion methods, if we see how many women adopt a method after abortion, you see, if woman has come for an abortion and we don't give her a method, we say we have failed her again. We have failed her again if she doesn't go back with a contraceptive method. So it has been seen that, of course, those who've taken a decision from a permanent method, it's okay, but then they take these short-acting methods, which are which they take very regularly, or rather stop after that. And after the medical methods of abortion, whether you take it from a public health, private, or wherever they take it, so they take only short-term methods are taken by 50%, almost 50% women. After a surgical abortion, that means when she comes to a facility, she has an interaction with the healthcare provider. But if they take an MMA, 80% of them do not take any method. So this is another fact to be kept in mind. Now, here I've put up a list of, as I was saying earlier, there are a lot of options now. After 2015 and 2016, government launched 2 newer contraceptives in the country, and just last year another 2 contraceptives were launched. So that means woman has a lot of choices, and So these are all the methods available. I hope you're all, these are pictures are actually from the public health facility, the commodities, but same thing is available outside. In fact, the LNG IUD, which is the hormonal intrauterine device, is not available in the public health system, is available, and that also, is a good choice even for the as a postpartum method. So these are all the items available. This is again out of all the methods that I have shown here, except the oral pills maybe, and the injectable. Immediately after childbirth, a woman can take up all methods, that is permanent methods. She can take LARCs, the long-acting methods. Now, in terms of, if I say call it long-acting methods, prior to 2016, there was only one, that is IUCD. Now we have injectable is also a long-acting method, which a breastfeeding woman can take at 6 weeks, and implants is available in select districts and states as of now. This is the first phase that government has launched. It is available in the private sector as well. So these long-acting methods and short-acting methods also, there's a huge choice now. So the plate is now nearly full for the woman to pick up any method that she chooses, provided we do a good counseling, tell her the pros, cons, everything about the method through counseling, which all of us have been talking about. Now, where do we get the information from all the methods which I am talking about? So I'm sure most of you have seen all these 4 cornerstones for family planning guidance. These are the WHO documents, and there are other many programmatic guidance for post-pregnancy, what to do, how to implement, how to address challenges, etc. A lot of literature is available, and at Government of India, we have reviewed all these lecture things and only then put up the methods. So here I would just like to share, a job aid, which is a very handy tool for all the healthcare workers, the FP OPDs, as a ready reckoner if this is printed. In fact, it is from the government point of view, we do share it with the public health facilities. And here it is so easy that if the woman is breastfeeding or not breastfeeding, which method she can take and when. So if you say it starts from 0 hours to 48 hours, so within 48 hours, you can see she can take all the methods, that is 1, 2, 3, 4, 5, 6, 7. All these methods can be taken within 48 hours. But the IUCD is one method which after 48 hours, she can only take at 6 weeks. Similarly, female sterilization is one method which she can take up to 7 days. And after that, she has to take at 6 weeks. And if she's breastfeeding, injectables at 6 weeks. So rest all the methods, even if she doesn't take at the time when she's in the hospital, she can come later on for later her subsequent visits, she can take any of these methods. I have not included LAM here because in India, it's actually a challenge rather that people confuse breastfeeding with LAM. And if you want to adopt LAM, it has to be done very, very systematically. A lot of training, orientation, monitoring of the client has to go on so that to ensure that she's really following LAM for it to be effective. Now, this is a similar chart which I showed you. This is for those who do not want to breastfeed. So those who do not want to breastfeed can take up the other methods as well. So this is a very handy chart. This is again a job aid. This is drawn from the WHO MEC book, very nicely put up all 4 categories for each of the methods and the conditions. I have just picked up few conditions from out of that chart and pasted here. And again, I'm just referring to Dr. Ashish's presentation where he talked about the eligibility of who can and who cannot take. So this is a quick, ready reckoner. So for post-abortion, all methods, first trimester as well as second trimester, a woman can take up all methods. They are category 1, except that even in case of septic abortion, she can take up all methods except the IUDs. accept the IUDs, and even after second trimester, it is category 2, the IUDs, because it requires a special skill to insert an IUCD in a woman who's undergone a second trimester abortion, and that's only because of the size of the uterus. So sometimes we have to use the same PP-IUCD forceps that we use for the postpartum IUCD. So see, so what the point I want to highlight is the choices that women have. Similarly, for the postpartum breastfeeding and non-breastfeeding women, again, many methods they can really take up, except of course we all know estrogen containing. So this is a ready reckoner. I've just picked up postpartum, post-abortion categories here to list that we have these handy tools which we can keep on our table, just those one pages or so. Now, again, emphasizing counseling, and that's something which is missing, which leads to discontinuation, which leads to dissatisfaction, which leads the private people, women who've taken a method at the public sector facility, go out to the private, and they increase the earnings of the private providers by getting it removed, as Dr. Shah was saying. So it is a critical intervention, because if you miss these opportunities of counseling the women here, you have really missed, she has really missed the train, and we have failed somewhere in our duty. So you can counsel a woman in the pre-pregnancy period, during antenatal period, all her visits, you can touch upon the topic of what she wants, or there are options available, so that she's able to decide beforehand, and you mark it on her card. And when she comes for delivery, whosoever is conducting her delivery or attending to her makes the arrangements for get her all the methods, the method of her choice there. And then if she doesn't take any method at the time, let her not take, let us respect her choice, and let her go back. And when she comes subsequently for a routine immunization or for a postnatal clinic, breastfeeding support, these are again opportunities. So we need to tap on these opportunities right up to 1 year, and we have to go on emphasizing the healthy timing and spacing after the birth. So similarly, for after the abortion, it is a slightly tricky situation, because when a woman comes for an abortion, either she may have been wanting to continue with the child, so there could be an emotional piece attached to it, or she could be clinically very, very bad. If she may come with an incomplete abortion, bleeding heavily, so that's not the time that we want to talk to her about family planning. So that situation again is to be assessed. So we assess her because every woman who's undergoing abortion comes for the procedure, we do give counseling for how the abortion will be done, so that's normal. So if she is emotionally in a stable situation, if as per your judgment, she is fit to understand about family planning, you can tell her then. Otherwise, let her settle down, let her come back, stabilize. That is the time that you can offer her, tell her about contraception, and tell her about the risks of conceiving soon after an abortion. And most importantly, tell her about the fertility returning. We've also seen a lot of cases that a woman undergoes an abortion and she comes back, she goes back without a contraceptive method, comes in the next month, doctor, मुझे तो period ही नहीं आया, आपने तो किया ही नहीं, abortion ही नहीं किया. So she conceives in the same cycle, misses a period, and then she puts the blame. So these are the points that we really need to emphasize in our counseling while giving her the services. So when she comes for a follow-up, if she doesn't take a method at that point of time, if she comes for a follow-up after abortion, that is another time that maybe we can talk about the contraceptive method. So having said that, I would once again just like to emphasize that respecting her choice, giving her exercise her rights is very, very important, and we should help her do that. Because you will agree with me that if a woman adopts some method by her choice, the continuation rate is much, much higher. Many studies have shown that already. And if you want to switch, let her switch, because now we have a lot of items in our plate, basket of choices. Let her take whatever she wants. So with those words, I thank Shobha and everyone else for your patient hearing. Thank you. Over, Shobha.
You can stop sharing.
I will stop sharing.
It was a
Thank you.
fantastic lecture. Very nice. And all that expertise as a as a master trainer in helping in the government sector as well as the NGO sector, all that is reflected in your talk. Wonderful messages you gave, especially about counseling. And Ranjana ma'am, your comment?
It was a very nice talk, and it gave us an insight into the actually talk, and it was really very good.
Thank
A
you.
lot of aspects have been touched, and I just wanted to say that I'm really grateful that Sunita could make it, because she has been very busy off late. She was the key person for developing the manual for implant. I think Manju also knows, Dr. Manju Puri, both of us attended the session together. And the training module for implant also, she was the key person to develop, and many other training programs from the government like that. I'm really grateful that you could make time today, and you gave the concept of post-pregnancy family planning so very clearly to Foxians. Just one thing which I wanted to bring out here, and I think everybody, all the senior Foxians will agree with me, and Shah sir is there to endorse it. It is not that, practitioners do not wish for women to have PPIUC, in the sense they are not looking forward to remove it at the slightest pretext. It is only that probably women are not perfectly counseled, and also the fear factor is not addressed. That is what I feel. That is the reason they come to, and then there is this kind of, that what is that called, stickiness to the method, which is there in the community. The bad vibes about the method which is there in there, and that is what feeds the fear. It is the feeds the fear. She goes home, she is resting with the baby, she's feeling that fear factor is being instigated all the time. And they're telling, oh, they have put the device, this will happen, that will happen. And she gets fed up of all of it, and she comes, and then she requests. And sometimes the thread does come out to bother her, and then she's totally, panicked, and she will come and get it removed. So these are the factors. So I understand what you're trying to say, but
Another thing I wanted to say was that actually what happens is that those females who accept the family planning methods will not tell anyone what they are using. But if any woman has any problem, she will tell to at least 100 women about her problem, and that this method is not good. Don't get it put. Don't get it implanted. Don't get a PPIUCD. Because I have seen this habit now. Because sometimes the other females who've got that method and it is being accepted very nicely will never tell anyone that go ahead and get it done. They will try to act very smart, that they are very intelligent, and hence the spacing. So it's the other females who have a little bit of problem also. They'll go and sing to hundreds of people that don't get it done.
I think, Ranjana ma'am, there is one lesson to be learned, that we have to become smarter than our women if we want to do some good for them. We have to learn to navigate around this.
And I think a major role is played by counseling.
Absolutely, madam. Absolutely. And a satisfied client, as we call them, champions,
Yeah.
they should be our promoters. They should be the promoters.
Absolutely. Yes.
So one good word for, and in major hospitals like something where I work, and Achla is also here, sometimes they will not listen to the nurses or the doctors. They will ask the ayahs who are moving around. And if ayah tells her, कि हाँ ये लगा लो तो या ये ले लो method, fine, they'll do it. But I'm just, the point that I want to say today is that we are evolving into a different era. As I said, paradigm shift. So as Dr. Shah said, he talked about PPIUCD. So that time only 2010 onwards till 2016, we had only PPIUCD as a postpartum method. But now we have so many things. So we must, look at those choices that we have and give the benefit of choices to the women and not just get stuck. And very soon implants will also be there across the country. So we have choices. So we must use those choices.
Excellent point there. So we have Dr. Achla who is unmuted, Dr. Maninder who is unmuted, and after that we'll go to the next session. Yeah.
Yeah, Shobha, Shobha, I am audible?
Yes, you are audible.
Shobha, I'm unmuted because I can't see that icon.
You are unmuted.
Achla, you are seen. We can see you. Okay, thank you.
Achla, you can speak.
You can speak.
After that, Dr. Maninder will speak. Please speak, Achla.
What I was saying was that Sunita said that ayahs, they listen to ayahs. So in Delhi, Dr. Manju and we as Narchi, we had that campaign that we were doing for anemia, that we were training the ANMs and the ASHA workers, the people who are most listened to by the patients. So I think for contraception also these things, if we have that kind of training for them, that would be really good.
It will be really good. It will be really good. Yeah. Maninder?
Yeah, Shobha Gudi, I think that was a wonderful webinar and need of the hour. And
अरे अभी खत्म नहीं हुआ है.
अभी Shobha has to moderate a panel.
Contraception,
yeah.
The Shobha thing is that we should expand. I think one thing is about paramedical staff. That is absolutely right, because they are more connected to paramedical staff than we are, because we are placing ourselves, I think, at a higher pedestal. Secondly, I think we should have that FIGO latest guidelines on the extended fourth trimester of pregnancy, because then we have a prolonged period of the consultation with the patient, when we can, if the patient had not accepted the postpartum PHD or anything at all, later on we can counsel them again, because we are getting that extended period maybe of 3 months when we can call them back again for whether they have adopted the methods or not.
Correct.
So that is the
बहुत
only
अच्छा
way.
Maninder. I just wanted to put in here that it's actually postpartum family planning extends to 1 year. And it's not just 3-4 months, and Government of India feels that the entire year is available. Any point of interaction in between, the woman can come and have the family planning services. So it's
But
an
we are not
extended
actually
post-pregnancy.
inviting them. Yeah.
Yes.
So
must
many,
be.
so many
appointment.
females are delivering by the end of 1 year.
Yeah, that is the
Again.
reason we should have an extended. So then there was one more comment about, and then we'll go on to this. Dr. Manjupuri correctly said that we must have more demand generation and we must have more number of beneficiaries. So thank you, Dr. Sunita. I think Bharti is not there. So Ranjana ma'am, we conclude this session and we go on to the next. Anshul, can you please introduce the panelists? Only the panelists, yeah.
So after 2 riveting lectures on postpartum contraception, I think we have a panel now, and it is going to be very interesting because Dr. Shobha is going to be moderating this panel. And all this while,
Go ahead.
Yeah,
Go ahead.
I will just introduce the panelists that we have. So we have Dr. Parag Biniwale, and sir is the chairperson-elect ICOG 2024. He's also he was the president of Pune Obs and
Go
Gynae
for one-liners. I think Parag will
One
not
line,
want you
one
to do the whole thing.
No,
Welcome, sir.
just one line.
Yeah.
Then we have Dr. Ritu Joshi. She's a senior consultant at Fortis Escorts in Surya Hospital, Jaipur. Welcome, ma'am.
Thank you.
It is my honor to introduce Dr. Manju Puri, my teacher. Ma'am is Director Professor and former HOD at Department of Lady Hardinge Medical College. Good evening, ma'am. I welcome Dr. Professor Achla Batra, who is heading the Department of Obs and Gynae at VMMC and Safdarjung Hospital, Delhi. Good evening, ma'am.
Good evening.
And good evening, Dr. Reena. She is Professor and Unit Head at HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. So over to you, Dr. Shobha, for this.
Thank you, Anshul. And I must really thank Anshul and Jigyasa, because we were told, we were thinking we should bring young ICOGians into this. And Anshul may be, a slightly younger than me only, must be a senior Foxian, but then she agreed to come forward. And Anshul, thank you very much for giving your practice time to ICOG. Come more and more. I think we need people, more and more ICOGians to get involved in all the webinars. Thank you very much. So with that, we shall go for a very, very crisp discussion on what are the common questions that women ask us about contraception, and what are the common issues which plague our minds as well. So I have just roughly put it as FAQs, and now this is going to be a more of an informal discussion, and that is the reason I took up with the most senior and the most knowledgeable of ICOGians. So let me just share my screen so that their experience just filters through and everybody can benefit. So I would request what is this? Yeah. FAQs in contraceptive practice, questions asked by clients to us or asked by peers is what I wanted to highlight here. In between, I'll be unsharing my screen also. I'll stop sharing. I can't see. Yeah. So I request them to be sure of answers, bust the myths whenever possible, myths for the providers as well, since we have providers here, dispel the misconceptions, and probably help all our practitioners to recruit new users and seal the leaking bucket. That means ensure continuation, because so many women stop using contraception on their own and come with an unplanned pregnancy. So the story of the pill, most probably our discussion will be around the COC today. So the story of the pill started way back in the early part of the last century, at the beginning of 1951, right? In the midst of the last century, when 5 of these people got together in New York at a dinner party. Let us not forget that it was shortly after this that India launched its family planning program, a nationwide, the first of its kind in the world. But then the program did not do as much as was expected for the nation. Nevertheless, these 5 Caucasians met together and decided that there was a pill which would help the entire world. That is quite okay from wherever it comes. Many of us are familiar with Margaret Sanger as the crusader for reproductive rights, and Gregory Pincus, who always said that it's only women who are dangerous, the pill is innocent. That means if we identify the risk factor in the woman, the pill most often does not cause any harm, and so on and so forth. So this is a story which is still today continuing, because the evolution of the pill continues today also in new forms and new molecules and new strengths. But what some of the things which remain forever are the questions like this. And one of the questions is, does using the pill increase a woman's risk of developing breast cancer? So I must unshare at this time and then ask, what are the facts about this? Are there any doubts, and do we have any kind of benefit in knowing about this? I just want to open the floor for discussion. Yes, we can go with Parag first. Yeah.
Thank you, Shobha, and greetings from ICOG. I welcome all my co-panelists also. Shobha, you brought out a very, very valid point, because whenever we are prescribing COCs, the first question that is asked by most of the women is that its association with cancer. And now we know that the breast cancer is one of the most, it is the most common cancer in our country. So I think we should use this opportunity to dispel the myth that the pill is going to cause cancer. Of course, selection of the patient is extremely important, but we should use this opportunity and tell the woman that how it is going to be beneficial, especially in certain benign conditions of the breast where she'll be relieved of her symptoms. We have to reiterate the fact that it is not going to increase the risk of breast cancer as well. I think Reena wants to say something.
So here, I think there are two important points. Most of the evidence says that in a well-selected patient, the benefits will usually outweigh the risks. Having said that, most of the evidence says that if you take the therapy for more than 6 years at a stretch, there is a slight increase in the relative risk of breast cancer. But here, what I tell patients is that if you never step out of your house, you are not going to be hit by a bus. But if you cross the road, you will take precautions. You will look right and left and choose wisely. And if you need to cross the road, you need to cross the road. So the same kind of analogy I give when we are choosing a therapy. And with looking at the non-contraceptive benefits, a lot of times the benefits far outweigh the risks. And in fact, most of the evidence has also shown that if at all breast cancer is found, because of vigilance, it is often picked up in a much earlier stage, and it is a hormone dependent, which is very well treated. So I don't think we should let this hold us back from prescribing the pills to people who really need it.
You know what? Can I speak something in between?
Yes, madam. Your turn only.
You know, we should actually even take a very detailed history of these patients, because if there's already a family history of breast cancer, it'll be better that we avoid it only, because we know that there are a lot of estrogen sensitive ones.
Okay.
But literature says that there is no increased risk in these patients who are at high risk. The risk is same for as general population. And also we must tell them that after 5 years the fuse, this risk is going to be the same as general population. And also that in younger patient, breast cancer is very, very rare. So I think the benefit of using pill outweighs the risk of that very slight risk, questionable, of having breast cancer increases.
Yeah. So if I have to give the figures, there's a Danish study which is published on more than 1 million users. And they say that in women who are less than 35 years, the risk is only 2 per 1 lakh women person years of use. And so that is only additional 1 per...
Very marginal.
Very marginal. And if it is more than 35 years also, then also it is 1 in 8,000. So it is minimal. And then what Dr. Achla said is very important, that it is only in the recent and current users. After 2 years or 2 to 3 years, then there is, once they stop using, there is no risk at all. So I think that is very, very important, that it should not, and let's correct it, that anyone who's got family history of, carcinoma breast, we can comfortably give it to them. There is no contraindication of giving.
MEX criteria 2, family history of
Yes,
breast
yes,
cancer.
yes.
Small increase risk ratio 1.2, decrease after 10 years of stoppage. This is what everyone uniformly said. I do agree with Ritu ma'am in one point, is that history is important. And if there is a past history of breast cancer, in such women, we do not use any hormonal contraception, not just COC, any of them. Some studies find women use more than 10 years, same risk, oh God. It is same risk of breast cancer as never users. That's what Achla was trying to say. And when current or former users of COCs are diagnosed with breast, the cancer is typically less advanced, like Reena said. And also, it is possible that women are getting screened more because they are on COCs, and therefore there is an earlier detection. So there is an earlier detection. It is less advanced. And then, as Parag said, it is really a bonus COCs for women who have tendencies. It's a protection against BBD. What is BBD? It is benign breast disease. Benign breast disease may be benign, but they really change the quality of life for the woman. So there's a 25% risk reduction there. And, there is a reduced risk of breast biopsies because of the decrease in this. Many times when there are BBDs, we tend to biopsy the women, and that risk becomes less when they are on COCs because the condition itself does not develop. So thank you for panelists for the very strong message that there is no cause and effect relationship and the risk is marginal and also related to the duration of use. And to complete the picture, please understand that it is the progesterone which is linked to the risk of breast cancer and not estrogen. Okay, does using the pill increase a woman's risk of developing cervical cancer? Yeah. Achala, can we start with you?
So yes, there is an increase in risk of developing cervical cancer with use of pills. Slight increase, probably because the estrogen lets the HPV be more persistent than it would be. But the risk is not that much. And again, after stopping the pills, after 5 years, the risk becomes same as the general population. It's not
Thank
that
you,
risk is going to
Archana.
persist.
So there is a marginal increase. There is a marginal. Unlike in breast where everybody agreed that the risk is very insignificant, here there seems to be a significant risk. Reena?
There are two things we have to consider here. It is the demographic pattern of the people who use COCs. It is more about the fact that the young, more sexually active women who are likely to have regular sexual intercourse, not using condoms, which are protective, and maybe multiple partners are the ones who have been using the pill for the benefit of protection from unwanted pregnancy. So in fact, 1 or 2 meta-analysis did suggest that maybe there is a skewed, there is a slight increased risk, definitely because of the more ectropion also, which may happen when you are on hormones. But there's a demographic pattern also, which is probably responsible. Hence, we should not let this fear of cervical cancer.
Definitely not.
And in fact, I feel that the message of safe sex should be like the belt and suspenders approach, where you are using the condoms for protecting yourself and having safe sex, and the pill for making sure that you don't get pregnant. So that is the message I usually give young people who ask me for contraceptive advice.
Parag, I was hoping you will give one practical input here.
No, Manju wants to say
because you are
something.
so
Yes.
pragmatic, yes.
So from my side, I think it is very important to know that, it does increase the infection with HPV infection. So this also brings us to a point that we should, promote HPV vaccination also. Yeah, so that is important. And then, of course, what Reena said, it has to be a dual protection, which should be kind of
Thank you,
encouraged.
Manju. Thank you. Parag, anything?
No, I totally agree with Manju and
Yeah,
Reena.
that is what I was expecting that
Dr.
only.
Dr.
That
Shobha,
this is the
should-
right
should
one
we-
to promote vaccination. Ritu ma'am, are you there? Dr. Ritu Joshi. Okay.
Dr.
Yeah,
Shobha,
Maninder.
yeah, if we are when we are prescribing these women with the OCPs, should we take this as an opportunity to call them back for checkups at what intervals?
हाँ मैं करती हूँ yeah, we
This
must
is an
offer them
opportunity
regular
when we are
cervical
prescribing this.
screening. I think everyone will agree that we have to just let me just complete the information on that. Yeah, so the facts are, as everyone said, there is an increased risk. It is 1.3 to 1.8-fold cervical cancer, but still considered slight only. And the woman takes the pill, when the woman takes the pill for more than 5 years, and they have a higher risk of being infected with HPV, again brought out well by Dr. Manju, than those who do not use the pill. Why? Achala tried to explain it, but actually it is not very clear. Some research suggests that hormones might help HPV enter the cervical cells. That's what she was also trying to say. Is there any doubt? That is what Reena was saying, that who use the pill may be more active and less likely to use protection, and that is how. So it is also to do the behavior, the health seeking behavior, or in general the type of clientele that we are seeing. So then let us understand that the risk of cancer is usually determined multifactorially. As far as COC is concerned, it will depend on when it started, duration, whether there is any genetic risk, and as we said, the sexual behavior. So there is a lot of evidence to support all these statements. Okay, so women who use pill, okay, I'm sorry, the question did not come. Does pill increase a woman's risk of developing ovarian or endometrial cancer? Let me not go to the panel on here, because everybody knows that it reduces the risk by 50%. There is some cross noise which is happening. So thank you. So the protection against these two forms of cancer will actually continue beyond stopping the pill. That is also very important. And of course, the bonus is that benign diseases of ovary and the uterus comes down when women have used it for. That is also a very big added point here in favor of pills, because it causes so much stress for the woman if she develops even an ovarian cyst or a fibroid suddenly in the middle of her life. So let me share and ask one thing of note is, does this fact come into the counseling when we start prescribing the pill? Ritu ma'am, aapki bari hai.
You know what, most of the myths which are around, I think we should address this point, because we should assure them that there is no risk of having cancer and starting, because lots and lots of them, the first question they have with us is this only, that will I get cancer if I use it? So and so had it. So we must, I think, in counseling bring up this point.
And the protection against cancer, we must highlight as an added point, is that it is going to protect them against cancer. And very few medications in this world have that quality, that they can protect against cancer. And COCs are credited with that. So I think it is safe.
Shobha, I would like to mention one point. You talked about genetic factors in cancer. When you look at the BRCA1, BRCA2 gene testing, which is now widely available in our country also, in fact, one of the few interventions which has been suggested to reduce the risk of ovarian cancer, even in BRCA positive patients, is the use of the combined pill in the younger years. And in fact, that is something, because the risk of breast cancer is very marginally changed, but the protection against ovarian cancer is highly significant. So if you go through the ACOG and the USPTF guidelines, they in fact suggest rather than knock off the breasts and the ovaries, they have suggested continuous screening and use of this. And the important thing of doing this BRCA testing is also to be done at a younger age. There's no sense in doing it when you're already in the age group risk for breast cancer. So if you're doing screening, it should be at a younger age.
Yeah. We next come to, I think this slide has come a little early. I must take this. A 36-year-old woman with DM and hypertension, which is so common today, she needed an MTP of 11 weeks due to contraception failure. Now, having given her the safe abortion service, I would just like to ask the esteemed panel, which method would you advise her now? And the next question is, can we advise the contraceptive which failed and resulted in pregnancy? For example, if it was an IUCD which failed, can we offer her the same, or if it was a pill which failed? So let me start with Parag this time.
Yeah, okay. Now, first of all, this woman really needs a good contraceptive counseling. We have to ask her what contraception she was using. If she was a pill user and if she has missed pills in a significant number of days, I think it may not be a great idea to prescribe the same pills and allow her to make the same error. So here I would
in view of the hypertension, maybe
absolutely. So here I would prefer some contraceptive which would be a long acting, which will not meddle with her medical disorders. So if I have to put it as the choices, my first choice would be a LARC, like an intrauterine copper device or an LNG intrauterine system, or even something like an implant which would be of great help. And for this woman, I think I would, my first choice would be an intrauterine device.
Thank you so much. Anybody else?
I
Manju,
feel,
your experience. Yeah, Reena.
So this is a classic case where we have to think about her age group also, and the fact that she's 36, she's likely to be in that phase where she's a risk factor for corpus cancer syndrome as she grows older. So a LNG IUD, in my opinion, would probably be the best choice for her.
Excellent answer.
In
Yes.
this case. And it would take care of everything without having, of course, we can't forget that we have to do the cafeteria method and offer her the entire choice, but the counseling should be directed in favor of the LNG IUS.
Manjuji?
Yeah, so I think Reena has made that point. It is very, very important that it has to be a cafeteria approach. So even if she missed a pill, I would, again, if she understands that and she wants to continue, it should be her choice. But of course, keeping in mind the hypertension and the diabetes, we would definitely, kind of counsel her with something which will help her.
Okay for her. Only pill maybe.
Yeah, which will help her in prevention. Subsequently, she'll be more receptive to that. Prevention of, cancer body uterus.
And
So she'll be more receptive.
Yeah. Correct. Ritu ma'am and Achla, do you wish to add anything?
No, I think
made.
Yes, Ritu ma'am.
No, Achla speaking, no?
No, I said the point has been made. Yeah.
Yeah, even I think everything is very clear.
That is what I just wanted somebody to take up, that it's the preventive aspect which LNG IUS offers to diabetic women in particular against endometrial hyperplasia. So does the pill cause blood clots? This is one important question I wanted to ask, that the use does come with an increased risk of blood clot. Rarely it results in major events like embolism or stroke, but the risk is 3 to 7 times higher than the never users. And recently, the US FDA also said that there is, 3-fold increased risk with levonorgestrel and a 6-fold with drospirenone. So some effort at putting the progesterones apart there. And the FDA continues to emphasize that the risk is still small, even when when using a pill that contains drospirenone. And women who are pregnant have a high risk of developing blood clots anyway. So let us get a take from the panelists on this, and let us see.
Dr. Shobha, I'll just give you an incidence. I had this young girl who was on the contraceptive pills, and I won't say exactly adolescent, but she was into that time frame coming out of it, and she'd taken it for a long time. But suddenly she came with a massive headache and loss of consciousness, and a lot of evaluation was done on her. And ultimately, the culprit turned out to be the contraceptive pills which she was on. So I think, the minute they complain of, we should actually tell them that if there's any history of dizziness, you get any headache, you get any nausea, vomiting, please, get back to us with that. Instead of, waiting for it to develop further. I think these are the true alert signs we can make them aware of.
Correct. You're very right, ma'am.
And I think what you said, Shobha, earlier, it is not the pill, but the woman who's to blame. And we have to be very, very careful in asking about the history, to elicit that, whether she has any risk factor for embolism. Otherwise, like somebody said, pregnancy also puts the woman at risk. The people stop becoming pregnant.
Tremendously, yeah. Anybody else with any quantification of risk?
No, my take on counseling the patient is that it's very important that we quantify the risk and give them an explanation, saying that in pregnancy, say it would be 20 to 30 per 10,000 women, and whereas with COC it is just about 7 to 10. It is much lesser, 5 to 6,
10 to 15,
5 to 6 times
say,
lesser.
per 10,000 women. Yes.
Yeah. So I think that kind of comparison which will hit them is something which should be put across. Same
and
about
in
cancer.
Non-users, it is not zero. In non-pill users, non-pregnant, it is not zero. it is
Yeah.
still 3 to 5 per 10,000 women.
Absolutely,
So
absolutely. So that
that
is what we
also we
need to
have
tell
to tell them that in the general population, it is not zero. Yeah.
Uh,
So,
Shobha, sorry, sorry
yeah,
to.
yeah.
Go ahead.
Yes,
Parag,
Manju,
go.
Manju, I'll
Go.
speak up.
No, go.
Yeah.
No, I thought, while choosing a pill, probably I would not choose a drospirenone pill because, if you compare all the set of pills that are available, drospirenone probably is the one which has the highest chance of having thromboembolism. So that is something which we can avoid. Certainly.
If there is history, you mean, if there is family history.
Yes,
Maybe
yes.
if there is family history or something.
No,
Yeah,
even
but in
no, Shobha,
general,
even preferentially, why should we go in for drospirenone unnecessarily? It does not have any additional advantages unless the patient.
Today, even in my practice, the most commonly used pill is the one with drospirenone.
No, but
the
I'm to say
benefits are simply
no,
too huge.
No, we should actually kind of not promote that. That is what is my personal feeling.
Can I just add to this? The drospirenone containing pill became very popular because it was perceived that it has the least weight gain and the effects. But however, a lot of the evidence is showing that the anti-androgenic effects and the effect on hirsutism and skin is as good with your other with levonorgestrel containing and desogestrel containing pills. So that advantage is no longer there. And
The
sometimes it also
anti-androgenic
happens.
properties are highest. So for
Yes.
PCOS, who is very commonly seen today, it becomes a kind
So,
of, a good
Dr.
molecule
Manju,
for that.
I also use the drospirenone containing pill widely in young women who are having issues of hirsutism, weight gain, body image, and pigmentation, along with therapies like when they are doing laser or other things for their cosmesis, because it seems to work best. But for long-term
works very well.
contraceptive protection, I think we need to rethink. Like Parag
I
said.
think,
So,
I
so
think
levonorgestrel
No,
pill
pills-
maybe.
Reena, just a second. You know what I'm trying to say is I also used to use it, but with the new evidence which is coming up, it does not give us that advantage for what we've been using it. So I think
So
it
you
is a
feel
kind
it
of
was
dilemma.
overrated.
It is, it is overrated. So it is a dilemma which we need to, the cost effectiveness also can be taken into account. So, the ones with levonorgestrel are cheaper as compared to what they are with,
In fact, in the public health system, levonorgestrel containing ones are free. So in
Yeah.
fact, so there is
Government
no
has
question.
not stepped up the pill at all. Government
Yeah.
has not said it remains the same. It remains the same.
I would like to make a point here that
Yeah, Achla.
as a contraceptive pill, I would not use drospirenone. But for somebody, needs to be tailored when PCOS patients are there, their contraceptive or pill needs have to be tailored to their symptoms. There, probably I would use drospirenone, but not as such as a contraceptive method.
Okay, so every OC pill has its place. That is what it is looking like. Because I don't think it will be productive to. Yes, anybody.
Shobha,
Yeah.
sorry.
Yeah. You please continue. Please continue. Yeah.
Parag, unmute. Parag, unmute yourself.
Sorry. Shobha, I'm sorry. I need to go and because I have a lecture scheduled at
Yeah,
Mumbai
I know
OBGYN
that. It is
Society
past 6,
webinar.
sir.
Yeah,
I'll
so
also
it is
try
at
to wind up
6:15.
quickly.
So
Thank
no.
you very
So
much.
I'll
Huh?
quickly deliver the lecture and join back because we
Thank
have
you.
all four
Wow.
experts who are talking, and I think if the discussion is going on, I would certainly love to join back and learn from them.
Thank you, Parag.
Well, thank you,
Thank you
Shobha.
so much.
Yeah, thank you, all
thank
the
you so much.
panelists.
So it may or may not be, but we welcome you back. Yeah. So I will be very happy actually. So the cardiovascular risk also is multifactorial. And we not only look at thromboembolic disease, we are also worried about myocardial infarction and cerebrovascular accidents, which are both of them are arterial accidents, whereas thromboembolic is venous accident. So we look at the whole picture, and we often, we must be very cognizant of the fact that the estrogen dosage is also very important. Progesterone and type of progesterone. There is always the genetic element, and there is always the behavioral risk. So whenever we put women on COCs, we must evaluate the genetic risk. I think Ritu ma'am said very correctly, and even Achala said very correctly, that the history is very important. So, in fact, for women, since we are dealing with women who will be, potentially becoming pregnant also, which is a highly procoagulant state, we must rule out any major thromboembolic tendencies, thrombosis tendencies, taking a very good history. So the good family history, we should all become adept at identifying how to take history of a thrombotic event, and then we must do a good job of it. So we shall go ahead here to the next. Do you believe in pill break? Now, having said all this, for women who are taking it for a long time, there are many women who require pill as therapy for a long time. For example, PCOS, for example, endometriosis, and then AUB, and for contraception. So should she give a break so that the body gets a rest from hormones? Because she may ask you that. So what is the take of the panelists on that? Yeah. Pill break, is it beneficial? Stop for 6 months and start, or 3 months and start. Anybody?
Honestly, I feel it is all in the mind. It's just sometimes patients
There
have
is
this
no
belief
science
that
behind it.
there is no
You're right.
scientific evidence to say that a pill break is going to help in any way. In fact, if she is not regular with taking it, she's more likely to get pregnant when she's taking this pill break.
Exactly. There is no science that a woman should take a break of continuous use. And the
the other thing
fluctuation,
is,
very rightly
if at
said,
all-
can cause side effects to reappear and increase the risk of an unintended pregnancy. Yeah, anybody was saying something? Yeah.
Yeah, I was saying that if at all there is a risk of thromboembolism that is there in the first year, and then it remains the same and even decreases. Everybody who
Not
gets will
making
get it
any sense.
mostly in first year.
Correct.
So if we keep stopping it, we are again putting her to that risk. So there is no point of a pill break.
You are very right. You are very right. And then also these pills get excreted from the body. That's why it should be taken every day, because it doesn't stay beyond 24 hours. So therefore, need not worry. Can a woman use emergency contraception as a regular method of family planning? Now, this is a very kind of primary school question, but I thought that, I will take, how do you tackle when you get such women who come with emergency contraception issues, who are using that only? So how do you tackle that? Because it's very common. It's an OTC product. Yes, please. Anybody can.
They come very frequently. Yesterday only I had a patient who has been doing this emergency contraception and has had 3 times MTPs with me. And these are the patients who are
Failure
into
rates are
relationship, who are into relationship. So that is what they are thinking, that by using emergency contraception, perhaps they won't get pregnant. But because of the irregular periods, we know that it's not happening. But I have found these youngsters who are into relationship, they are misusing this.
Correct.
And we have
Very
to
right,
counsel
Manisha.
them.
Manju, can you tell me how you are tackling this issue? Because how do you change them into regular method users?
So basically, we would not have so many patients of, coming to us. But what is important is that we try to dissuade them by explaining it to them that they will have irregular cycles. And no one wants to have irregular cycles. So if they use it once, then that means they are taking extra dose of hormones, unnecessary hormones they are taking is going to harm them. And then, of course, you can try explaining them that barrier is something which should be always be there. They should carry condoms in their purses in case they can have an encounter anytime. So rather than...
So another thing is, if Achala or Reena would take this, or Ritu ma'am, after a woman takes CC, will she be protected from pregnancy until she gets the next period? That is the other question that women ask us.
Yeah. So here, I think there are 2 things. We have to emphasize that why is it called emergency contraception? It's only used for an emergency, not as a regular contraceptive method. And if she's having another act of sexual intercourse, she needs to use some other form of protection. That it will not be protective to her, but sometimes they do have a slight delay in the subsequent period, which again causes concern to them. So I think we have to emphasize that emergency contraception has to be reserved only for an emergency. and it will cover only the next 72 hours, but she should not take a chance.
Okay, now I request somebody to mute from wherever the noise is coming. By using injectable contraceptive, this is another common concern. Maybe if she uses for 3 years, 4 years, injectable contraceptives, will it cause bone density loss? Does she become weak in bones? Should we tell them that it is harmful
So,
for the bone?
Shobha, there has been some studies which have suggested that DMPA, when it's used for more than 6 months, it may lead to a loss of bone density because you are having a hypoestrogenism because of the progesterone action. But most for the young active women who are there up to 2 years, I think injectable can be used. I don't know what our other
Actually,
Manju ji,
if
kitna din,
being used for
Achla, kitna
women
din
more
use
than,
karte? Huh?
if being used for women who are more than 20 years, when they've already had their bone mass, whatever they had to have, probably it not be that harmful. But yes, even the guidelines say less than 18, we should not be using it.
In younger women, it is not evaluated. Yeah,
I think
Manju ji?
it's 1 to 2 years, Shobha. In case it's used for more than 2 years, then it does cause some decrease in bone mineral densitometry. But then it says that it kind of it's reversible.
It's
That is
reversible. It
yeah,
reverts back.
reversible.
It bounces back, but also it can be minimized by a very active lifestyle and very high calcium, vitamin D,
Absolutely,
etc.
absolutely.
It can be
Those
minimized.
things have to be
But then, but then I have heard many of this NGO sector and even public health sector. They say that they provide they have free outlets for Antara, and they provide for 5 to 7 years also without any incidence of fracture happening. So probably it is again a little bit overhyped. And I'll just complete that slide and go ahead with the next matter. So there is evidence it contributes to loss, especially in the hip and lower spine within 2 years, as Manju said. And the risk is, of course, more when the woman smokes. And she also has low calcium intake. And adult women regain after they stop, as we discussed. And current research is examining whether bone loss in adolescents and young women is fully reversible. This is the concern which Achla had, that she said less than 18 years or less than 20 years, one should be cautious. It's because that reversibility during the peak bone mass acquisition, whether it will be complete or not, because that is when acquisition of bone is happening. And if we interrupt that with this kind of hormone, whether she will regain the lost one later on. Okay, so that is, so maybe for WHO says unintended pregnancy at young age outweighs the risks of a fracture later in life. Okay, so that is something to be remembered, that the risk, the benefit is outweighing the risk here. The benefit is outweighing the risk here, because if that is the only thing available for her, maybe then we have to provide that with necessary caution. A very redundant question, but maybe essential for the audience. Can nulliparous women and adolescent girls use intrauterine devices?
I agree to it. I support this statement of yours. They can use and they should use, but taking a precaution of a dual precaution, because the partner should also use a barrier method. But I agree to it, instead of missing out on tablets and coming to us again and again. I think that
Anybody
the
has
companies are
experience?
becoming very successful.
So Shobha,
Karina.
here I would like to say that I have a lot of my relatives and this who are in the US under insurance for the collegians. The LNG IUS is being offered to the young adolescents, even if they say they are unmarried or not sexually active, if they have menstrual disorders, or for protection against getting pregnant. So here again, as Ritu said, and as I have said before, the belt and suspenders approach. Use condoms for safe sex, but putting in that LNG IUD will also help a lot of the young women who have, but of course not within the first 2 years or so after they start menarche, but it is very helpful for girls.
A bit later, yeah.
And I have actually used it in a couple of young girls, the LNG IUS particularly, for a combination of protection against pregnancy and also for menstrual disorders.
Reena, I was looking for Skyla and the slim ones. I have not yet found it. If that is available, that will be great for our girls. Yeah.
Shobha, I just wanted to find out, do we have smaller IUDs available in the market?
Wait, that is what I was trying to tell.
Yeah.
Skyla, it is called the slim one. The
I will
slim
tell you,
one.
there are two available. There is something called as Emily and Levodiva, which is it is LNG IUD.
Emily is LNG IUD. No, I'm talking about copper T.
less, but it's small. Yeah, but copper T I'm not preferring that. Yeah.
Copper T.
Because it'll be very nice to have a smaller one so that, we can offer it.
Absolutely. I agree with you. Yeah.
Shobha, are you going to discuss Implanon?
I'll see. What an unnecessary question is what I thought. Maybe we will, Dr. Maninder. Maybe. So this is the one on Implanon. How long is the surgical procedure to insert and remove an implant, and does it hurt? So this is a patient asking the question. Can our experts answer this? All of us are now doing implant insertions and removals. So how much time does it take to insert and to remove? And is it hurt? Does it hurt? Is it an OPD procedure? Yes, it's an OPD procedure.
Yeah, I mean, I don't think it hurts because I have used even those, nerve plant. There were 6 limbs. Even then, patients are willing to put it, and they still ask. So one limb is, I take only 5 minutes, and taking out also 4 minutes. So it's a very good thing which patient really wants. They still keep asking us, if this is available.
We should keep telling them it is more like an injection, so it will take very little time. We're just going to give a little local and then give it. So that is all what we need to tell them, that it will not pain. And removal also is going to be very easy. And Shobha, patients are really opting for, implants.
In the public sector, it's a hit already.
Huge demand.
And whatever feedback I could get from the follow-up of 2 years or so, even the follow-up is quite good.
Yeah,
very few people are coming for removal. Most of them are continuing. Yeah.
They are so much more, less anxious that there's nothing which is going into their uterus. So you tell them they all wanted one injection. They don't like pills, they don't like copper teas inside the uterine cavity.
Method, yeah.
So you
and
tell
the
them
fact
injection.
that they can palpate it.
Yeah. And
the
this
only thing which we need to improvise as far as implant is concerned is to manage the irregular menstruation which happens in about 20% of women. If we become good in that, then I think continuation rates will be very optimal. So that is one thing which is still bothering. I hope that we can solve those issues very quickly. However, won't be possible to discuss. The average time 2 minutes and average time to remove is 4 minutes. Majority of users have not reported excessive difficulty or pain during insertion or removal. So this is from the feedback. Local anesthetic and bruising, minor pain or bleeding and scarring may happen, and rarely infection may happen, but they are all very rare. Now, is there any risk of cancer when women are using injectable contraceptive, the depot? Is there any risk of cancer? Any panelist can offer, because I'll now go ahead with this. Anybody wants to say can say. Similar to oral, injectable also protects the woman against ovarian endometriosis. And 2012 study linked to heightened risk of breast cancer for women.
So I think, Shobha, there were studies in beagle dogs which initially said that progesterone was linked to breast cancer. And in fact, that's why there was a lot of uproar in the initial introduction of DMPA, particularly in Southeast Asia. But the additional trials did not show anything.
That's what even I found, and I have put, Reena, you are very 100% right, that additional clinical trials and research have been insufficient, and whatever has been done has not shown. So we are getting a call to wind up from Nilima. So I don't know how much more I can do.
I'm sorry, Shobha, I also have to leave now because there is.
Thank you, Reena, for your support.
You so much.
I will just see what else I have, and quickly I will wind up, because I think that was a useful discussion and I knew the time required will be less.
So I think, Shobha, why don't you, concise the whole panel yourself only, will be far, far better.
Shobha, please unmute yourself.
The new dose of the subcutaneous medroxyprogesterone acetate, I think all the experts will agree that the dose is less by 30% with the same efficacy. It is 104 milligram and it is subcutaneous with the same duration of action. And orniloxepin also is a good option today. So please suggest it to your clients. And the dosage is also very, very friendly. It is twice a week for 3 months, followed by once a week after the 4th month. And actually, very few women do not qualify for Centroman. Maybe as of now, for PCO women, the evidence is not strong in favor of Centroman because it causes asynchrony in the endometrium, and we do not know how it will affect the state of hyperestrogenism in PCO. So better we avoid there as of now. And this is about missed pill, of course, that if she forgets to take 2 pills, then what she should do. And many of us have had this problem, and she just has to take the next pill and continue
Shobha,
the rest
I
of
have
the
a point here. Shobha,
Yeah.
I have a point. If she misses
Boliye.
2 pills in the first 10 days, then she
Yeah.
has to use extra protection.
Correct, correct. Because that is
We
the
must remember that
pre-ovulatory
that
phase.
because that can be it can lead
It
on
can
to a
result
failure.
in pregnancy. I know that. It can result in pregnancy. Okay. Now, this is about quick start of COCs, quick start. And she has just come from somewhere and her LMP was 20 days back, but she still wants the pill. And can we kind of start it now? Because then, start it today, or should we wait for the next period and start it within few days? So we can do a quick start. I think everybody agrees that quick start can be done if we are reasonably certain that she is not pregnant. Because, after 7 to 10 days of ovulation, only the pregnancy test becomes positive. So there is always a window period when the woman has conceived, but she is not manifesting with a urine pregnancy test positive. So for that, what we must do, that if the woman comes after 5 days since LMP, she can be started on the pill, but she needs to abstain from sex or use additional contraceptive protection for the next 1 week. And she should also report if she misses the subsequent period. With that caveat, she can be prescribed. Okay, so I think this question is not, okay, Malayan can be given if there is no history of unprotected intercourse since the last period. Backup method is also recommended. These slides are not showing her. This is good. If she wants to take the injectable, so that I will go ahead. I'll go ahead. There's too much of text here. Too much of text. This is also done, I think. Okay. She has come to the family planning OPD on day 2 and wants to start the combined pill. Any other essential or mandatory test has to be done before she starts, like a BP examination, a breast examination, PSPV, all of the above or one of the above. This is somewhere I will have to share the screen. This is one of the last, Nilima, please excuse me. Yeah, this is important because many times practitioners feel whether they should do all these tests before starting the COC. So what is your take? You should check the BP, you should do per speculum, PV examination, breast examination, everything before we give the pill, or we can just prescribe it.
Depends upon the method you're using. If you are using your copper T or IUCD, you have to do a PSP.
Let us talk
If
about COC.
for
pills, I
pills, you
think
have to
good
do
is
BP. Just a BP would be enough.
good history, blood
Good history,
pressure.
good
I
history.
think that should be okay. And of course, if I get an opportunity, I will definitely do a breast examination and do a, PAPS, not a PV,
As a
but a
routine.
PAPS, of course, I would want
As a
to.
routine, not
Yeah.
because of contraception,
Not
but as
because.
I
I
will
fully
make
agree.
use of the
As a
opportunity.
routine. That
Yes.
is the message to give.
Fully
Thank
agree.
you so much.
Yeah. We can
Thank
start
you.
it without.
Yeah. Somebody has said, Sandhya Shri has said it is better to do because, you have the opportunity. Correct only. Whatever possible you must do, but you must also know what is the guideline. And the guideline says that, tests before contraception are divided into A, B, and C. A is essential, mandatory. B is contributes substantially to safe and effective use, and C does not contribute. So the blood pressure comes for B and C. The BP comes as class A, and PSPV comes as class A for IUCD, diaphragm, and cervical cap.
Absolutely.
Sir, I'll come
Yes.
to you, sir. I'll come to you, sir. Just a minute. Let me just finish. Unnecessary examination and tests may create barrier, and adolescents are not comfortable. So I think we'll skip all this. We'll skip all this. We'll skip because there is no time. There is no time. And this is the eligibility criteria. This is about copper T shelf life. We'll skip it. This is about tubectomy. We'll skip it. This is about certification for sterilization. No. Okay. Okay. This is the last question. Informed written consent signed by the client is required for providing the pill, the POP, the EC pill, the injection DMPA, the centromen, the IUCD, all of the above or none of the above. So what is the take of the panelists?
It is actually none of the above.
Yeah, you're right. You're right, because contraception is a voluntary choice and nothing is needed. So thank you for patient hearing. Reproductive freedom is non-negotiable. Promote contraception to prevent unintended pregnancy. That is the message to be given to everybody. And I must thank the lovely panelists for having patience. It might have appeared trivia, might have appeared very fundamental and basic, but I think it's very essential for all of us to keep revising these facts. So thank you very much. Thanks, Manju.
Thank you, Shobha, for having us here. It was interesting interaction.
I just wanted to make it. Yes. So,
An
Parag,
excellent
thanks for
moderator,
joining back.
Shobha, with lots and lots of academics also in it. It was a lovely panel. Lovely
Thank you, Ritu ma'am. Oh, coming from you, and I must share with
There's
everybody
nothing like that.
Ritu
An
ma'am has
excellent
been my
panel.
guru, and she guided me when I was kind of training to become a chairperson for Family Welfare Committee. So thank you, ma'am, for being there. Thanks, Parag, for joining back. That means a lot to us. Parag, let us take a message from Rustam Sunawala, sir.
Yes.
Sir,
we need to
unmute, sir. Unmute.
Okay.
No, there are a few points I would like to mention.
Yes, sir.
It is now nearly coming to 75 years of contraception that India as a country has been practicing. We have not yet made an indent or any effect on the healthcare providers to understand that a small family norm is a necessity for every family to be healthy. So it's more the health providers who require. The second thing is we cannot leave behind the method of postpartum sterilization because India is a big country. People complete their 2 kids or maximum 3 kids by the time they are 25, 27. And they have still 20 more years of menstruation. So all the spacing methods are excellent for spacing a kid. But once the family is complete, we have to rely on either tubectomy or tubal occlusion or vasectomy. We know the problems of vasectomy. It's finally the female who has to bear the brunt of childbearing, and therefore tubal occlusion should be the main thrust in our program following the completion of the family. The fear that by chance they lose a child is much, much less now than what it used to be 50 years ago. And even if they lose a child, we have IVF. So even if the tubes are irreversibly damaged, one can offer IVF if a couple for emergency requires to have a pregnancy again. I appreciate the excellent discussions which have been taking place and the interest and the time given by each speaker. I've been listening to the whole program, but please do not forget postpartum tubal occlusion as a good method of our country, because 75,000 deliveries a day, we cannot rely on spacing methods all the time. A permanent method, well selected, well planned, will be the answer for our country. And the last point which I mentioned, when we crossed 1.4 billion, the country was said that we are a young population, we are a growing population. But people were not told that India is only 2.6% of land surface and managing a population of 16 to 17% of the world population.
Yes.
So that is the big problem in the country. Limited land mass and overpopulation compared to all other countries, whether China, Russia, US, where the land mass is big and the population is small. These points have to be expressed to the politicians who seem to be very proud that India has crossed the Chinese number in the population. It was a great handicap to the country. Our
Yes.
progress cannot take place if we have so much of young population jobless, educationless, homeless, and foodless. That's not the population we want for India. I thank you for the patient listening, but don't forget postpartum permanent method will be the solution for India, maybe for the next 10, 15 years. Thank you very much.
Parag, your concluding comments, Parag.
Yeah, thank you, Shobha. I'm really sorry I missed the panel discussion halfway through. It's always pleasure to have somebody of the stature of Dr. Soonawala here, and I must appreciate Dr. P.K. Shah sitting all through the program. Thank you, sir, for being here and gracing the occasion, especially in the ICOG program. Shobha, you were excellent as moderator as usual, though I missed half of the discussion. On behalf of office bearers of ICOG, thank you all the speakers, all the panelists, and our program convener and moderator today, Shobha. And thank you all the delegates who have sat through all through the last, say, 2.5 hours of family planning. And this is something which we intend to continue even in the future. So Shobha, a lot of work for you next year, and
I'm
we
ready,
will
Parag.
come back
ready.
with a lot of programs, because as Dr. Soonawala said, this is of national importance and we should do our bit to contribute to it by imparting knowledge to our members. Thank you.
Yeah, sir, आपका blessing आखिर में.
See, you are a fantastic master when it comes to panel, Shobha, and you had picked up gems of Foxy. All of them were very disciplined, very experienced, and gave fantastic messages up to point. And it was an excellent webinar on family planning. Please continue to do so and wish you all the very best.
Thank you. Thank you. Anshul, can you just give a brief vote of thanks, because I think we don't have much time with us.
I know, with shortage of time, first I would like to thank you, Dr. Shobha. With World Population Day around the corner, you have chosen very relevant and selected topics which have been really informative. I thank all the ICOG office bearers for taking out their precious time from their busy schedules to make time to be a part of this webinar. And a very special thanks to all the speakers and all the panelists for contributing and providing their experience, sharing their experience with us. Thank you, Dr. Soonawala. Your concluding session was the most important.
Icing on the cake. Icing on the cake.
Exactly. And to conclude, I would just like to say that we all have understood that contraception is a choice. But with all of us sitting at positions where we can make a difference in people's decision, we just have to be more sensitive towards this issue, and we will surely make a dent in the population.
Very well said. Thank you, Anshul. That's lovely.
Tell me.
So thank you. Thank you once again.
Okay, bye.
Thank you. Thank you, everyone. Good night.
Whenever, anytime now.